All right, well, welcome back. And it's my pleasure to introduce the next panel for you. Tulip is a member, one of our newer members as well, and one that we were just extremely pleased to have join us. Christine, for a number of years, would come to our meetings and come to learn, come to build networks. She was always so open, and open is just doesn't begin to cover it. I need people with more vocabulary than I have. But she was always just so open to sharing information, to discussing tough issues in a way that was very easy to do. And so we were anxious and very pleased when they were able to join us, and we've learned a lot having them. And what we're doing with this panel is we're going to focus on Tulip and a couple of their partners, and to take the conversation we've had that started very broadly and move down to almost a country level. We want to take it now within a country to look at how attitudes about health, how policies and culture help drive the creation of some of these organizations and their relationships. So Christine and her panel have graciously agreed to do that for us. And by way of just brief introductions, in case you are not familiar with them, and I know this morning I didn't mention this, but I'm sure all of you by now have picked up a copy of the bios. And we'll also be making them available online as well. But Christine Perrier is director and head pharmacist at Tulip. In France, I'll let her tell you about Tulip. But she's one of these people that I really value knowing, where they've had experience across a number of functions and capacities in the work that we're doing. So she's worked with Pharmacists Without Borders, the French Red Cross. She moved to Tulip and was the first head of donations, and today is their director. What they do is, we don't have a member that does exactly what Tulip does in terms of putting together emergency kits in the way that they do, but some things are very similar, the use of volunteers, some of the focus around what they do. And so I think having her perspective is important, but she also has a very broad perspective in terms of the issues. And so we're very happy to be able to ask her to participate here today. She also plays an active role in developing CSR policies for the pharmaceutical industry and is Tulip's representative to meetings of public health authorities and with French Foreign Affairs Ministry, excuse me. Now, Nikki Blackwell, I have not met. She's a specialist in internal medicine and palliative medicine intensive care, as well as has a diploma in tropical medicine, trained in England before moving to Australia, where she worked in remote parts of that country. She's also a major author for 2 textbooks, and so that may be unique to our panel. I don't know for sure, but certainly she knows her stuff, and we appreciate having you here as well. She has also worked in a number of field contexts, including with Sans Frontières, Doctors Without Borders, as an anesthesiologist and critical care specialist. So very welcome, and look forward to hearing from you. And then Dr. Fares, how did I do? Close enough? Is a surgeon and has a master's in public health and manages the medical department at AMI, and since July 2010, and responsible for reviewing and implementing health policy in the organization as well. I encourage you to look at their bios and bios of all the other presenters as well. So it's my pleasure to turn it over to Christine first to start the presentation and our conversation. Thank you.
So, good afternoon. How does it work? So, as Claire told you this morning, there are some new members in PQMD. I'm the new member with the funny accent, as you will see. So, today I will present you my organization, Tulip, through a French perspective, which is also a bit a European, because we are working with European NGOs, European donors, and our companies who are funding Tulip are French, of course, but they are also global. So you will see that we are not only French, but we are really European in the way we are working. So Tulip, a health partner model in transition, we operate, first of all, under a specific health partner model, It's a platform for emergency aid that provides assistance to emergency NGOs, mostly European, and this essentially through donation of medicine on behalf of a French Federation of Pharmaceutical Companies. This year we have around 60 members, 60 companies that make donation to TULIP in order to be able to respond in case of emergency crisis. I will not be presenting you with what TULIP is today, but rather with what our organization will be tomorrow. Indeed, after a very full year of operation in 2010, we embarked on 2011 by carrying out a comprehensive examination of our activities and the changes that we must make to improve the quality of our emergency preparedness. So, as part of that process, we carried out analysis of the changes that have occurred in all those involved in emergency humanitarian aid in France and in Europe. Our aim was to ensure that TULIP adapted to the same changes. So, we began by examining the profile of our traditional partners, emergency NGOs, as I told you, mostly French, but some of them are European. And we actually made our first finding. The very nature of their operation, emergency operations, means that these NGOs have to innovate constantly, and they have to adapt their action to geopolitical and technical context that will change with every intervention. So, as a result, we are seeing a growing professionalization of emergency NGOs. They have become veritable enterprises, able to mobilize not only health professionals, but specialists that are skilled in the techniques and constraints of emergency situation. Let's take an example. 10 years ago, the expats who left on humanitarian mission were 25 years old. Today, for the same type of intervention, the average age is 35. What used to be a step in the career of a young graduate has now become a career in its own right, and I'm one of these examples, actually. So in that context, so-called first-hand NGOs, primarily made up of volunteers and not benefiting from any international fundings, are disappearing little by little and are being replaced by more structured NGOs. And then in that framework, TULIP is still positioned as a supplier of medicines, specifically for the first few weeks or the first few days of an emergency. Up until now, this was done primarily through 3 different emergency kits, which were adapted to a large range of different partners. The professionalization of these NGOs means that it is now necessary for TULIP to review those existing kits and to develop new kits that are specifically adapted to today's NGO needs. As you know, as in all professional settings, these NGOs now use standardized structures that can be reproduced, and they deal with reference supplier. We want to be one of these reference suppliers. So we have therefore been working for some months on modifying our 3 traditional kits, and we have been working on the development of a 4th kit specifically for surgical mission. And this is, of course, only the beginning. Let's see now what we found when we examined the changes that have occurred among recipient population. Our finding, which is clearly positive, is that this population are far better informed than they were 10 years ago. They are no longer interested in one-off international aid missions, but they have become clients with specific demands and standards that have been developed during earlier crises or in conjunction with international donors. So during a disaster, it is not unusual to see a government itself allocate intervention areas to emergency NGOs or limit imports of humanitarian goods to an exhaustive list of products. In that context, as you all know, of course, pharmaceutical products are no exception, especially given the problems that will be associated with the disposal of donations that are not adapted to the situation at hand. So, one more time, in a world where the recipient has become a client, NGOs, based on goodwill and volunteers, without the time or the resources to develop appropriate tools for intervention, without standardized procedures, and without long-term projects, experience real difficulties in being recognized as preferred partners with significant added value for a recipient nation and population. In that context, the concept of associating TULIP with NGOs that are already recognized as playing a humanitarian role in the recipient country is important. So to that end, consideration will be given to entering partnerships with organizations that are already in vulnerable countries. This would probably enhance, and we hope so, it would enhance TULIP's know-how and reputation in an area where specialization has become an asset. We then look at donors. So TULIP perspective is the perspective of European donors. I don't know if all of you are aware of that, but European donors are mostly public. Most of the European programs are funded either through national systems, national funding agencies, like the French one, or through the European Union community with different offices, depending if the emergency is an emergency or if this is a development program. So this is really a public donor perspective. And actually, we made the same finding with respect to donors. In the past 10 years, donors have also evolved, both in terms of the NGOs they are prepared to work with and in the type of services they are prepared to fund. On the one hand, the current economic climate means that donors are more selective and more rigorous in the NGOs they will fund. And on the other hand, the types of services they are funded have evolved. 10 years ago, funding was focused on product, material, foods and medicine, with a minimum of technical assistance provided for the distribution of those products. Today, funding is focused on the logistics necessary to ensure the proper use of products, including transport, storage, as well as on the long-term development of programs through the funding of skills, training or technology transfer. And actually this change in the donors' focus means that NGOs also have to reorganize themselves, often joining together with other NGOs in order to satisfy the requirement of donors. So TULIP is evolving in the same world as those donors and those emergency NGOs. Given a more difficult economic environment, we, TULIP, also have to be more selective in our partner NGOs if we want to maintain the same quality of our services. And in addition, the demands of emergency NGOs have also evolved. 10 years ago, those demands were focused on donation of medicines, and today their demands are more comprehensive. They include the need for pharmaceutical capacities, management tools, and services related to the proper use of medicine. So as was the case for donors, we, TULIP, are also in the process of evolving our concept of donations to include pharmaceutical logistic skills that will optimize donation for the recipient population. And finally, what we have done during this study, we have examined the changes in recent years in the regulatory framework for drug donation, both at the national and international level. Let's start by the international level. What used to be the rule 10 years ago is now the exception. 10 years ago, the rule was the purchase of generics on the international market. It was advocated by donors. Then it was replaced initially by a requirement to make regional purchases in conjunction with a skill transfer, and it's currently replaced by the development of national purchasing centers. But a consensus remains on drug donations. Drug donations are still necessary in a very specific context, the emergency situation. Therefore, TULIP remains a legitimate player in its activity of donations for emergency situation. Now, if we look at the national level, in parallel to that international evolution in France, as early as 1990, the Department of Health created the status of a pharmaceutical establishment devoted to humanitarian NGOs. This provided a legal framework for the possession, handling, and export of medicine by these humanitarian NGOs. a number of NGOs immediately took up this opportunity to create such a pharmaceutical establishment. This was the case of Doctors Without Borders, CHMP, and Tulip, who were the first three to do so. 10 years later, in 2008, the Good Practices for Drug Donation were issued, and they were actually largely inspired by Tulip's own specification. These good practices acted as a reminder to pharmaceutical companies of their continued responsibilities when making donations to medical NGOs. And here again, Tulip, with its status of pharmaceutical establishment, remains a legitimate player in emergency donations. So in this context, so far, Tulip has succeeded to being a pioneer, following and even anticipating national regulation while complying with all international recommendations. That approach means that we are still the emergency aid platform for the bulk of pharmaceutical companies in France. But that position should also enable us to become the emergency aid platform for all healthcare companies present in France, and this notably by opening up our membership base to medical device manufacturers. In conclusion, this summary analysis of the evolving players and issues in the emergency humanitarian sector, mostly in France and in Europe, in which Tulip operates, has provided you with an overview of the challenges faced by Tulip today. In order to address these new challenges, we believe it is necessary to adapt our methods of functioning and the services we offer. So, first, to begin with, our involvement in almost all acute emergencies, which was based only on the demands of recipients, will evolve toward a proactive involvement in certain crises in cooperation with NGO partners selected in advance in order to make our assistance as effective as possible. Second, we will take into account the realities of emergency situations that are not only acute but can be structural. This leads us to envisage longer-term involvement in selected programs. Indeed, how ethical is it to be massively involved in an emergency that receives considerable media coverage without also providing some after-sales services? Third, the form of the donation made must also change. The format of drug kits, which was appropriate for the provision of first aid, is no longer adapted to the work of emergency NGOs we are working with. Medical devices will therefore be added to existing kits, and new kits will be developed with priority given to the creation of a surgical one. Fourth, the donation of products will be accompanied by technical assistance. It could be human resource skills like pharmacists, technical skill as supply management tools, or logistical skills. And finally, in a context of rationalization and stringent quality standards, the Federation of Pharmaceutical Companies, represented by Tulip, must expand to include a Federation of Healthcare Companies. This will allow us to achieve a higher level of financial autonomy and to include medical device manufacturers in our action and, of course, mostly in our emergency kits and the surgical kit in particular. So we believe that by deploying these 5 different drivers of change, we will be able to pursue our ultimate goal in a continuously changing context, which is to provide a sustainable, collective and high-quality offer to our partners NGOs, and through them, serve our recipient population. I would say to conclude that if you want to know more about our organization and our program, you can visit our website. We have an English version. And I will now leave the floor to 2 of our partners NGO, Professor Nikki Blackwell, which is the medical director of Alimam, and Dr. Annie Fares, which is the medical director of IME, with whom, of course, we have been exploring these different changes scenario. Thank you.
Good afternoon, everybody. Thank you very much for the invitation to participate. I have to say that I was rather anxious about giving this talk because I really wasn't sure who the audience was going to be. And although I give lots and lots of talks, it's always much easier if you know who the audience was going to be. And I found the evening last night incredibly useful, apart from just being a very pleasant evening, because what I found that linked us all was our humanity. And wherever we're coming from, whether we're coming from business, from an NGO background, all sorts of backgrounds, that's clearly what we all have in common. And then that made my talk and how I was going to do it much easier. I also discovered as you were saying earlier, people that we've partnered actually a lot this year in Haiti, here at this meeting, and had a chance to speak to them, even though I haven't actually had the chance to meet them before. So, really picking up on Christine's theme, I'm going to talk about ALIMA, the Alliance for International Medical Action, which is the NGO which I work for. Why we formed, because I think it really underlines some of the principles that you talked about. What our projects are in general, and some themes in that which I think will be relevant to many of your areas of interest. And then I'm going to speak more specifically about our experience with Tulip in Haiti in the last 12 months, and then just very briefly touch on our combined experience with Libya as well. So why was ALIMA formed? It was formed because we believed that times were changing, that although it was totally reasonable 10 or 15 years ago to parachute in an enormous machine, run a response to a crisis, there always comes a moment when you have to pull out again, and often that means leaving nothing behind apart from perhaps some medical equipment which nobody can maintain. And those of us who were the founders of ALIMA really felt that we never wanted to have to close a project again without feeling that there was something more sustainable left behind. Also because our experience between us, the founders, I'll talk about a little bit later, but between the 4 or 5 of us who founded ALIMA, we've got between us over 100 years of experience in the field. And that meant that we have a great deal of connections with brilliant local healthcare professionals in many of the countries in which we work. And we were talking about this a little bit at lunch. Although initially those people tended to leave, not necessarily to go to the West, but if they had an NGO background, to go and become an expat, for example, with MSF, which was the great kind of career goal of many of the doctors and nurses that we worked with 10 or 15 years ago. That's actually not what's happening now. And they're returning to their countries, and because we've all been quite high-profile individuals within the fields in which we've worked, contacting us now that they know ALIMA exists and actually asking us to help them to act as an incubator to let local NGOs actually start to control what's happening in their own country. We also believed that we don't have any ambition to become a huge NGO that responds to every emergency. What we're particularly interested in is innovation, in looking at the way in which we do things and questioning whether that's the right way to do it. And an example would be, there are so many knee-jerk responses in humanitarian medicine, but how you respond to a measles epidemic would be a classic example, when nobody's actually asked the question, what's the response of malnourished children to a measles vaccine anyway? And perhaps the reason we're seeing strange things in Western Africa at the moment with the measles epidemics, with strange mortality ratios and so on, is because we don't actually understand enough of the basic immunology about what we're doing. We don't believe that we can possibly have all of the competencies that we need to do our work. And so we believe that we should share competencies, and our partnership with Tulip's been an excellent example of that. But also in Haiti with the cholera, we've worked with Solidarity International and let them do the WASH side of things, while we concentrate more closely on the medical response. And then we also feel that we're obliged to research what we're doing and see whether it can be improved or whether, in fact, we're even doing the right thing. And so we were fortunate enough to receive a grant from the French National Research Agency for €400,000 earlier last year to conduct a 2-year project looking at the different outcomes in patients after the earthquake in Haiti who were either amputated or who went on to have a reconstructive approach to try and save their limbs. It's a huge debate in the response to, in the surgical response to major natural catastrophes and indeed warfare. We've also got a big research project which is ECHO are going to fund. It's probably going to end up being about a €3 million research project looking at the response to cholera in Haiti and putting into question the whole concept that it's inevitable that cholera will become endemic in Haiti. So, Alima, when were we founded? Who are we? How did we come about? What you see here is our first office, which was in the dining room of one of the founders. That's only 2 years ago. We've now grown to a pool of people who don't necessarily work full-time and aren't necessarily salaried, but who are all very experienced in the humanitarian field and who bring their various expertise to join us. So you have here the president of Alima, Thierry Alafort-Duverger, who is the ex-head of the emergency desk of MSF. And next to him, Eric Bardessin-Far, who we all know as Diabolo, who was the ex-head of the logistics section of MSF France. Between the pair of them, they've been present at just about every humanitarian crisis that's happened in the last 20 years. And more recently, particularly with Thierry and I were together in those in the last 10 years. And then here you have Augustin Augier, who I think you'll get to meet this evening or this afternoon, who's an ex-program director with many years' experience with MSF, and then many other experienced colleagues. So that's who we are. We were founded about 2 years ago in that dining room with a tiny budget of only €80,000 from La Chaîne de l'Espoir. For those of you who are French, who know a charity that looks particularly at paediatric cardiac surgery. And they gave us a free office that we moved out of, the dining room, although we've now moved on again, and some startup money because they needed our help with a boutique project. It's not by any means what we do usually, but helping a hospital in Baghdad to move from just doing adult cardiac surgery to doing paediatric cardiac surgery. And although they're very good at setting up projects like that, they didn't have a great deal of experience in the Middle East. And Thierry Diabolo and I spent the last 4 or 5 years before Alima was formed working in the Middle East with many contacts in Baghdad. So it was really with their support that we were able to get started. And we're lucky, this project, we were lucky because this is the Ministry of Health in Baghdad. And it was a project that was fully supported by the ministry and so on. So we were lucky to do that. We've moved on to having had a budget of about €6 million last year and projected to probably 10 million this year, mainly from, that's an operational budget, mainly from ECHO, but other funders too. So I'm going to talk briefly about our project in Niger to underline this feeling about working with the new leaders of these very troubled countries in Africa. So we're not talking about stable countries like Kenya. We tend to work in places like Niger, Mali, Chad, Congo, places that are very troubled and where the health infrastructure is really defunct. So here you have Dr. Kanta, Dr. Sani from our local NGO Bethan and another sister organisation, Forsani. Between them, one of these two I'm certain will be the Minister of Health in this country in the next 10 years. Many of their other colleagues who, as I say, have worked with large NGOs in the past, but all returned and decided that they wanted to work in Niger. Same again on the right there. So this project is a project in partnership with Bethan, the local NGO, of which there would now be about 300 local staff We only ever have one permanent expat in country with sporadic visits to help them set up logistics and so on, and UNICEF and the European Union. And I won't dwell on this too much, but this is fundamentally a nutrition project, but also looking at the major killers in the under fives, particularly diarrhea, malaria, and so on. And we're now trying to move away from a clinic-based service, and this is where innovation comes in. This was a meeting with the local women's group and the local key town representatives, our anthropologist, Moutari, who comes from the region, trying to look at how we could actually set up a village health worker-based system. And although I'm sure many of you are aware that that's been done in countries like India and Bangladesh, hasn't actually yet been done in an unstable context. And that's our next area, really. Malaria, for the pharmacists, where Artemisen comes from. I don't believe that for things like a major response to malnutrition or malaria, gifts from pharmaceutical companies should count. I believe that this is a global responsibility and that the big agencies like Rollback Malaria and so on are the ones who should undertake these projects. They're huge. We know that the World Bank estimate for looking at malnutrition across the world and actually treating it properly is a $10 billion exercise. I think for the malaria program, it's very important that we have a standardized decision on what our approaches, our drugs and our protocols are going to be. So moving on, this is the hospital side. And again, this is just to emphasise, really, this is our hospital where we initially started treating children just with very severe malnutrition and complications who couldn't be treated in an outpatient capacity, although we've now gone on to become a paediatric referral centre by default. This is based in the local district hospital, so it's not a standalone parachuted-in structure. Again, we're trying very hard to be integrated within the actual way in which the country works. And here you have the head of the health district and the sultan of the health district, who and the politics in the country is such now that they're actually refusing to let international NGOs come and work in nutrition programs. There's a huge drive in Africa now to actually have local NGOs taking on the extra projects that the Ministry of Health aren't able to do. The difficulty with this in terms of obtaining funding is that they don't necessarily have the street cred, which allows big funding agencies to give them large amounts of money. They don't necessarily have the credibility yet, or indeed the, I don't know if you would call it skills, but certainly the tenacity to fill out a 50-page ECHO grant form. Here is something where perhaps, though, we will be starting to ask for help, because here again, this is a child, the mother has AIDS, the baby has AIDS, that child needed to be admitted to hospital with its malnutrition, and we already know how much donation in kind is done in terms of the response to AIDS throughout Africa. But many of these children, this is during the malaria season when they present with severe malaria and decompensated heart failure, but often with sepsis. And I think we're going to see in the next 3 or 4 years a real need for help with antibiotics, because the resistance to ceftriaxone has now spread pretty much across the whole of East Africa, Central Africa, and it's now starting to affect us in West Africa. We know that children with malaria are susceptible particularly to gram-negative sepsis, and we're running out of easily accessible antibiotics that we can treat them with, that we can afford. So moving on to Haiti and Tulip, and I put this photo in not because there's anything particularly interesting about this poor person's foot, but because there's a tulip, there's a tulip box there, which is what our donations arrived in. So why has do we feel so passionately, positively about our relationship with Tulip? I think it's because if you look back to when the earthquake happened in January last year, we were tiny, we were baby. We'd only just moved out of that dining room. And we wanted to respond immediately. We were fortunate to find a hospital which is run, a private hospital, but which was still standing with impeccable operating theatres, because the Haitian surgeon is married to a French architect, and so the building had been built to withstand earthquakes. And we contacted Tulip, and the response was immediate. So that ability to meet, to discuss what we needed, what we knew we would need, because we've all been to many catastrophes like this before, and to ask for those donations and then actually be able to sit together. And I think Thierry, Augustin, and Diabolo and Christine spent many hours in the warehouse kind of going through the kits, because at the time that wasn't an existing kit. But that ability to reply and respond immediately and to listen to what the operational needs were was extraordinary. But it was then followed by more than that, because this was a huge project. We treated over 2,000 patients, and we performed over 800 operations in that first phase. So it wasn't a little project. And it was the continuing response. It was the fact that there were visits to look at the project, to look at what was happening with the organisation of the pharmacy. But it was collaboration. It didn't feel like the police coming to visit. It felt like, okay, well, how's this going? How are you organising your drugs? How are you using them? What could we do better? Are there things that you're missing that we could change, and so on? It certainly didn't feel like a policing visit, even though it was monitoring and evaluation. It was a genuine collaboration to look at our work and see how we could do it better, as well, of course, for Tulip to look at how their donations were being used. So that was the earthquake. And again, because of our previous experiences in earthquakes with the Iraqi civilians who were injured, we knew that there were bound to be some deep-seated bone-related infections coming next. And Christine and I discussed this as early as February last year, although it usually takes 2 or 3 months for those problems to emerge. And we also know that, unfortunately, often some of those infections are multi-resistant. And so then you start talking about drugs like meropenem and vancomycin and even piptaz, things which are not on the WHO essential drugs list. And we'd already planned, we knew that this might happen, and indeed with some of you in the room, we've been able to treat those patients appropriately with the same kind of treatment that we would consider appropriate in our own countries. And then the cholera happened. And of course we responded to that. We had some real pragmatic difficulties around the first tour of the elections, because one of the things you've got to have is water in a refugee camp if you're trying to control a cholera epidemic. And there's no piped water in Haiti. And so the trucks that were delivering the water couldn't get through. It was an intense time. And again, what happened was, because Haiti's second language is a francophone country, basically France ran out of Ringer's lactate because the NGOs that were responding were all francophone, and their supplies were coming more or less from France, and you can't respond to cholera if you haven't got on average 10 litres of Ringer's lactate per patient per day, which is a huge volume. And again, that was a huge problem for us, and Christine was the first person we got on the phone, and we worked out ways around that, ways of finding local suppliers in San Domingo. Really, that response we wouldn't have been able to do in such huge quantities. And we treated thousands and thousands and thousands of patients with a hospitalised death rate of less than 1%, which is the target that everybody's meant to aim for, but sadly often isn't achieved. We, again, with innovation, everyone kept saying, oh, it's so terrible, there's no ambulance service, patients can't there's no access. And so what we actually did was we engaged a fleet of tap-taps, which are the local multi-occupancy taxis, employed some of our ex-patients from the earthquake as switchboard operators. In collaboration with the government, they gave out an emergency phone number. And then we turned these tap-taps into cholera ambulances against The taxi drivers were a bit shocked that we cut a hole in the bottom of their taxis. But basically we've lined them with tarpaulins. This is a nurse and a hygienist. And we were able to respond and get the patients to care. And again, I had Christine's permission to show this photo. So I could tell you that Tulip's given us, I don't know how many tons now. We must be up at about 100 tons of equipment last year. That it totals almost 100,000 euros. But actually, that's not really what counts. The relationship with Nadine and Christine, the fact that this is Christmas and New Year this year, we were in the field together for a very tough 3 weeks when all this supply issue with the ringers was happening. And we scratched out on the back of an envelope what the cholera kit's going to be, and we've got that sorted now. And what's actually happening here is that this is one of our logistician colleagues who unfortunately had a very severe attack of dengue. This is 2 of our nursing colleagues, and basically we sat up and looked after him for 2 nights. And you can't really replace that kind of experience or that kind of relationship. So just to finish briefly, we decided that we weren't operationally big enough to mount a response in Libya where the security contexts are really very difficult, and that we didn't have sufficient contacts in Libya to be able to do it properly, that really a big organisation like MSF is much, much more appropriate in that context. However, again with Christine, we became aware of an organisation that was taking supplies into Libya and also shipping people out. And so we decided between us what kind of donations we could make in terms of medical supplies. So even then we were still able to come up with some kind of collaborative response to that emergency. So I'm going to finish there really by saying that for us, the partnership with Tulip has been nothing but positive. As a doctor who continues to work 25% of my time in a very high-tech environment, I'm used to having highly skilled pharmacists as colleagues. And to be able to plan complicated antibiotic regimes with a senior pharmacist as a colleague is indispensable. That to try and decide which vasoactive drugs we're going to take with us to Iraq in terms of storage and transfer, even though, in fact, it's not that Tulip supplied them, but to have that kind of skill available is invaluable. It's the rapid response, the operational context and understanding, the continuing monitoring and evaluation, but done in collaboration. And then finally, the complete openness to innovation, to looking at what kind of kits we might require for the future. Thank you.
Good afternoon, everyone. We are here since this morning listening to this nice English language, but we forgot something, that we are in France. That's why I decided to make my presentation in France, because I'm sure that you are missing to listen to this fantastic language. So I'm going to talk about the collaboration with Tulip, collaboration of Aide Médicale Internationale. So before I'm going to present you a bit who is Aide Médicale Internationale. We started en français. Alors, on a commencé en 1979.
And we used to go out in twos, we would discover what was happening on the ground, and we would train and gain experience. It was entirely pro bono, and we had to become structured and be able to work on a permanent basis. Afghanistan is a very important moment in our history. not just because it was our first mission, and also today our biggest single mission, but also because we had a very significant event there when our current president was abducted in Afghanistan. It was an important moment because after that we decided we had to rethink who we were, and we opened up our first HQ here in Paris. We have been working for 32 years, 34 countries, but obviously we're not in 34 countries today, in 10 countries currently in Afghanistan, where we support primary healthcare activities and also the two national laboratories in Kabul. We work in DRC, Haiti, on obstetric care, Myanmar, and Thailand in two big projects. In Thailand, we work in the Karen refugee camps at the Burman border, in Yemen, Central African Republic, and North Korea. In April 2011, just 2 months ago, AMI joined forces with another organization called Première Urgence, PU. So we merged, and to give you a feeling for what we now represent, we serve 2 million beneficiaries on a yearly basis, 139 people working in the field and at HQ, 16 countries where we are active, and 150 projects. The reasons for the merge, essentially so that we could be multi-sectoral, so that we could have an integrated health approach, primary care, mother and child, HIV, but also nutrition, water and sanitation, rehabilitation, infrastructure, and economic stimulation. The values, however, have remained the same: to empower local populations and make our action sustainable, not substitute, give direct aid, hand our gifts, our donations directly to the beneficiaries, and go where others cannot or will not go. We are constantly seeking out the highest degree of vulnerability in the excluded populations, those whom conventional aid has forgotten. But back to the subject and how we work with TULIP. Let me take as an example Pakistan. Following a humanitarian crisis in July 2010, Pakistan was hit by major flooding, which caused 1,600 deaths and thousands and thousands of homeless. We decided to take action, and so we went off firstly on an evaluation tour with Arnaud, who is here today, and myself in August 2010. Essentially, it was primary health, hygiene, and nutrition requirements that we identified. Then we had to go fundraising, find donors who would help us respond to the need, and set up our activity as identified. At that time, there were TULIP and Sanofi. We contacted them, and they made it possible for us to take some very significant action. First of all, donating drugs, find a doctor and a GP and send them out there, and air transportation and warehousing. And so we were, with their assistance, able to respond promptly to needs pending the agreement with OFDA, our partner, which was signed a couple of months later. So in other words, this helped us save 2 months.
Alors, notre projet, comme vous voyez, on
We
a
worked
travaillé
in
à Lacana.
Lacana.
Je pense que je dois appuyer quelque part. Ah. Dans la province, dans le district de Lacana, dans la province du Sindh, dans le sud du Pakistan.
Village in the Sindh district, south of
Notre
Pakistan.
projet final
The
était amené avec 3
the
cliniques
ultimate
mobiles
project was to go in with 3
qui
mobile
ont donné
clinics,
des activités aux bénéficiaires de 49 000, 50 000 bénéficiaires.
49,050 beneficiaries.
On a pu
We
envoyer
sent
5
in 5
expatriés.
expats,
On a pu embaucher 37
and we
employés
hired
nationaux.
37 local
Et on
employees,
avait un projet
and the
avec un
project
budget de
budget was
$760 000.
$760,000.
Alors, grâce à l'appui du Tulip
Thanks to
et de dans des
Tulip
médicaments, de ces de
and
42 kits de
the
médicaments
42 medical kits that we got
obtenu
thanks
grâce à
to Tulip,
on a pu aide
we
médicale
AMI
internationale
were
a pu
able
réaliser
for the
pendant les 2
first 2
premiers
months
mois
to organize
6,719
6,719 consultations,
pour des enfants de moins de 5 ans.
1,478 for under
Vous voyez
5s.
un peu sur la
When you look at the
répartition,
breakdown,
c'est les maladies
you
les
can
plus
see that
récurrentes
the
qu'on a rencontrées et qu'on a pu
commonest
soigner avec les
diseases were
donations
those
de
we were
Tulip.
able
Infection
acute respiratory
respiratoire
disease,
aiguë,
skin disease,
various
lower
pain,
respiratory tract infection, weaknesses, diarrhea,
diarrhea,
eye
and
infection.
infection.
These were the ones that we encountered most of and that we were able to treat
Si on
using
regarde un peu,
those,
en analysant un peu
using the
les forces
equipment donated.
avec les kits Tulip ou les cantines
Looking
de Tulip,
at
on trouvera les points suivants.
strong points,
C'est clair, une réponse rapide
with the
dans des
Tulip
bonnes
contribution,
conditions
it was quite clear we were able to come up with a very prompt
à une
response
situation médicale d'urgence.
to a true medical
Donation de
emergency.
médicaments de qualité,
Quality drugs were donated.
disponibilité des médicaments
The drugs were
Tout de suite,
immediately
dans les
available
24
within
heures,
24 hours,
jusqu'à la
right up
livraison des
until the
donations
delivery
faites au
of the
niveau local,
donations made
soit par
locally
l'OMS,
either by
soit par
WHO
l'achat d'un AMI qui se
or
fait
by
à l'international.
AMI international procurement. We
Disponibilité des
had
médicaments de base,
basic drugs,
comme les
antalgics,
antalgiques et les
antibiotics
antibiotiques, qui est
available,
nécessaire à la prise
so
en
that
charge
we were
de la
able
majorité
to
des
start
pathologies
attacking
rencontrées.
most of the diseases
La
we
date
met.
d'expiration
The
médicaments étaient
expiry
relativement
dates were
éloignés, ce
relatively
qui a
long,
permis
so we were able
de
to
les stocker
store
plus
the
longtemps.
drugs for a relatively long period of time.
On ajoute un petit peu le bon
Very
lien
good
entre
working
Tulip et
relationship
le
between
MAE qui
Tulip
nous a
and
permis
the
de
French
traiter ces
Ministry of Foreign
cantines et
Affairs,
ces kits jusqu'à
who helped us
Islamabad.
transport and stock assistance
Par contre,
in
rien
Islamabad.
n'est parfait. Il y a
Obviously,
sûrement toujours
there's
des
always
petites
room
faiblesses.
for improvement,
Ces petites faiblesses, ça
and
vient
our weak
d'où?
points
C'est des donations de
essentially
médicaments
concern
françaises.
the donation of
Donc,
French
les médecins
drugs,
pakistanais
and
connaissent pas.
obviously the Pakistani physicians
simplement.
are not familiar with them.
Donc, on est
So we
obligé
had
de faire une
to
traduction
translate,
et faire un gros
and,
glossaire à donner pour chaque équipe
draft a
mobile qui
glossary
partait.
for each mobile team that went out there.
Certains médicaments
Some
ne sont pas du
of
tout connus pour les
the
médecins, donc il fallait
drugs
faire une
were
formation pour les
totally
médecins
unknown,
pakistanais.
and we had to train the local doctors.
La composition des kits
The contents
n'était pas
of the
forcément
kits
adapté
not
à une stratégie de
necessarily
clinique mobile
appropriate
qu'on a
to
choisi
a
finalement
mobile
comme
clinic, which
organisation
was
de
our
mettre en place.
preferred form.
Donc, on se trouvait avec
So we
beaucoup
found
de
ourselves with a
formes
lot of
injectables
injectable
et de
forms
matériels qui ne
and
sont pas utilisés.
various types of
Qu'est-ce qu'on a fait? On a pu
equipment
donner
that were difficult to use.
ces matériels et ces
And
médicaments
so we
à
simply
d'autres
ourselves donated
structures
all
de
that
santé
to other
comme des hôpitaux dans
health
notre district.
structures that could use them,
Il
essentially
nous manquait
local
quelques
hospitals.
formes pédiatriques,
We were short
il
of
manquait des
pediatric
médicaments
forms, we are
essentiels
short
comme
on
pour traiter des
essential
pathologies dermato
drugs
et ophtalmo comme le
for
traitement de malaria.
diseases, the most frequent diseases,
aussi,
malaria
par contre,
in
on avait un
particular, and eye
surplus
diseases.
de médicaments
And we had,
pour des maladies chroniques comme le
excess
diabète et
drugs
l'hypertension.
for chronic diseases such as hypertension and diabetes.
Alors
If
si on regarde un peu
We
l'évolution
now
de
look
cette
at how the
collaboration,
working relationship developed over time.
notre première collaboration
We
avec
started
Tulip a
with
été à Haïti.
Tulip in Haiti.
C'était pas une très bonne
It was
collaboration, c'était pas une
less than
bonne
successful.
réussite de collaboration.
We
Pourquoi?
simply
Parce qu'on ne se
didn't know
connaissait
one
pas.
another.
Parce qu'on
And
ne savait jamais
we were
rester
not
ensemble,
good at sitting
discuter,
down
connaître
together around a table talking about who is TULIP and who is AMI and what do we do and what do we do together, plus the additional difficulties caused by the earthquake. Pakistan. Before going into Pakistan, we had several preliminary meetings with TULIP. We were getting to know one another better, and I was part of the canteen day, in other words, where the so-called canteens are prepared by TULIP. The result was that coordination was much better, and today we are able to draw on that positive experience from Pakistan, and we are now able, and this has proved to be the case in Côte d'Ivoire, we have been able to make appropriate orders and appropriate deliveries. So 7 crates of bags went out for the first. We didn't really know what the contents of each container was. Today, we know what we need and how to be better at providing the right contents and know what each container has to contain if we're to be efficient on the spot. I said that it was an evolving, ongoing working relationship, and we're now looking at projects to train personnel, transport drugs and kits, and perhaps new concepts, new surgical kits, which we are discussing at the present time. Thank you very much. That was our experience with TULIP, and thank you for your attention.
Merci beaucoup.
Sorry, we're switching gears here a little bit, so now you have me. So before we open this up to questions, I do have one question for the group here. And thank you for being honest about your experience in Haiti and other disaster response efforts. We really appreciate that. I'm curious to understand, though, when you were doing your needs assessments in these disaster response areas, if you did receive inappropriate donations, how were you receiving those injectables if they weren't the right kind of product donation for a disaster effort? Can anybody answer that question? The bottom. It's on the bottom? There's a... Not working. Yes.
It's not working now. You are asking about the donations that you receive. Actually, what our experience with TULIP, it was a fixed set of kit. So of course we couldn't choose part of the drugs and part of them not. That's why we are now like they have 3 sets of kits. And you had to order number of these kits adapted to what our strategy and what I'm going to do. So if you are expecting now, we know that the set is covering this number of consultation for pediatrics and for adults. So I think the experience now that we get lately on Côte d'Ivoire, that we knew exactly how many kits we can order on this and how many kits we can order on this. Of course, there will be an excess of some drugs here or other drugs not used. And that's why we are keeping discussion, keeping exchange of experience so we can adapt more these kits
Okay.
That's it.
I think our experience was a little bit different, but it's mainly because Christine and Thierry and Diabolo, I was in various places with me on the phone, went to the warehouse and pulled loads of stuff out of the kits and chucked other stuff in. And although the kit that itself didn't exist at the time, we sort of made them up at the time, didn't we? And so we didn't really have quite that same experience. The other thing that was happening in Haiti, which was excellent, is that the people who stayed, if you like, I would call them the serious players, had a very good system going between them of sharing drugs. Either if we had too much of something, we would share, and then they would give us back something that we had less of. So we didn't have quite the same experience, I don't think.
If I can add some details about the kits, there are advantages and disadvantages about kits. Advantages are the kits are already ready in advance when an emergency happens. So the advantage is that those drugs are already in our warehouse, they are available within a few hours, and they can leave. But in parallel to that, we have to be very strong and very transparent in what is in each kit, because the aim is to find a situation that usually we don't know what we will find, so we live with some quantity of kits and just try. Am I back?
Yes. Yes.
Yeah? Okay. And we start to work, and then we start to, as an NGO, to ask for extra medicine, and we just discover that some of them won't be useful on the field. That's also a reason why our kits are very small. It's 50 kilograms kits, because the aim is absolutely not to bring some unusable drugs, but to be prepared to everything. And what we are usually doing, and I think we've done that in Pakistan, because IT was not with kids, we find agreement with other NGO locally that we are sure will use these drugs.
So you mentioned the agreement with other NGOs for the products that you can't use. How do you find out if they need it or not in advance, or how do you have that network? Veronica did a study in Haiti and was trying to figure that out for PQMD on, how to establish that knowledge base during a time of disaster.
Well, the first thing to say is that Veronica, I'm delighted to say, is actually in the middle of writing an article about our experience in Haiti, which is great. And thank you, Veronica. We're just working on the second draft at the moment. Well, because we've all known each other forever. We've all been together everywhere. and so in every... And I'm talking about the serious big players. Everybody moves around a little bit, but there'll be at least one or two people on the coordination team of each of the senior players that you've worked with before, or you've met before, or you were in the same team together 10 years ago somewhere. It's really a word of mouth type network. Mm-hmm. But you find out very quickly who's who and who the coordination teams are of the main responders. And there's always somebody you know. And if you don't know, well, then you just go and see them.
Mm-hmm. Does anybody have any questions? Oh, Alan, please introduce yourself and say which organization you're with.
My name is Alan Cohen. I'm with Henry Schein. We're a distributor of healthcare supplies and services in 25 countries. My question actually relates to the kits. And in times of disaster, one of the issues that we're always interested in Hello?
Yeah.
One of the issues that we're interested in is understanding how easily, or if the product can actually make it through the border. So the question is, with your experience in having these prepackaged kits that exist that are in standard format, are there particular arrangements that you have worked out in advance that a government or customs agents, a customs division of a government will allow these through? Are these worked out in advance? Does it depend on the specific international NGO or local partners? Just how does that work to ensure that at a time of, especially at a time of disaster, that piece happens
I think we'll share the answer because you will have several answers, but you will have mine first. The thing is, TULIP is a French NGO that was created in 1982, so a lot of people at the French border already know us. It means that we never have any problem to leave France when there is an emergency crisis. When we arrive in a country, we are also working for 30 years with the French Ministry of Foreign Affairs, who are very often assisting us to transfer the medicine. So what usually happens is that they are offering some space on their plane, which means that if it's a plane of the French Foreign Affairs Ministry, there's no border or custom issue when the plane arrives in the country. Otherwise, I think I would give the micro to my partner.
As you say, we've had the advantage recently of benefiting from Christine's experience, but what I've experienced, particularly natural disasters, is that usually, and this is what happened in Haiti, for the first few months, in fact, providing that stuff is coming through under the auspices of an NGO, it usually gets through relatively easily. Unfortunately, what happened in Haiti, well, and it happens everywhere, it happened in Pakistan after the earthquake, is that after a few months, I'm sure everyone's experienced this, the customs then become very active. And we found our way of doing that has been more recently to benefit from Christine and Tulip, but even with that, to cultivate relationships with the Minister of Health early in the country where we're hoping to operate. And really that's been the most efficient way of getting things done if they actually arrive. It's for the Ministry of Health to know what you're expecting, why you're expecting it. So one thing for us would have been, for example, after the customs were reintroduced in Haiti, we had ordered a big C-arm X-ray machine for doing complicated orthopedic procedures. And we knew it was coming, and it was worth a lot of money, and the Haitians had decided they were going to start imposing a tax on stuff that was coming in, and a storage fee if it didn't get cleared, and it was potential to cost us thousands and thousands and thousands of euros, and so we short-circuited that with the Ministry of Health. I mean, I would say the country that's probably the most difficult, I don't know how much experience, I'm sure there's some more experience in the room with this, but probably the country that's the most difficult still is Iraq. And that's because the Ministry of Health have decided to centralise all of the donations in a big central depot and to then control themselves where those donations go. And there's a certain logic in that. There really is, except for in practice it doesn't really work terribly well. And we've been very lucky this time. It's certainly not the case in some of our other Iraqi operations, but in this time, because our operation's so sanctioned by the Ministry of Health, we've actually been able to get our donations delivered directly to the hospital, and they kind of fly through customs with some sort of seal on them. But in general, Iraq's still a nightmare. Actually getting what you want to where it's supposed to go is very difficult. As long as it gets used, in the end, that probably doesn't matter so much. The concern in Iraq is how much of it's actually getting used and how much of it's staying under lock and key or finding its way onto the local market.
I'm going to add a small thing. Completely right with what Nikki said. I just want to add that we have the same problem even when we buy drugs from Europe. Like recently, we had the experience in Pakistan. We were buying drugs internationally from Europe, and with WHO authorization, ISO, all what you want. But at the end, these drugs were fabricated in India, and Pakistan don't allow drugs coming from India. So you can meet this type of problem everywhere, and still not.
Sorry.
Just say where you're from again, please.
Yeah, Maya Morris from AstraZeneca. It was just to build on that question, because I noticed that some of the work that some of your organisations had done was in Libya, and when you were describing how you got it through, it sounds as though there's quite a heavy dependence on the local kind of government and relations with diplomats, and of course in a situation like Libya, that's quite problematic. So I just wondered, in that kind of situation, how you get stuff across borders.
We didn't go to Libya, so
we send medicine to Libya through different partners. One of them, which is not here today, is the French Red Cross. And we were working one more time with the French Ministry of Foreign Affairs, because as a diplomatic representative, they have access to customs without all these difficulties. So honestly, when it's very politically complex or dangerous, we go through a diplomatic issue to be able to cross the border. That's always have been the best way so far.
And then sometimes you just put it in your pocket.
You run then.
Go ahead, Kavita.
Kavita Bali from Pfizer. I'm a bit new to the drug donation world, but have worked in the field before, and a couple of times now an issue has come up about off-label use of product. And there's obviously appropriate and inappropriate use of off-label use, I think. So I just wondered if you had studied that at all. I know in Haiti, for example, azithromycin was requested. It wasn't exactly on our label, the indication for cholera. So I wanted to kind of understand how you deal with those issues.
Okay, antibiotics in cholera. There's a no, but that's a very interesting question, because off-label use, I think the question I ask myself in any kind of healthcare that we're delivering in a country is, would this be acceptable at home? And if it's not, then you probably shouldn't be doing it. So that's the first thing. And I think, again, coming back to Christine's point about how NGO actions have changed in the last 10 or 15 years, it's no longer acceptable to do a laparotomy on a kitchen table with a headlight, because it wouldn't be acceptable at home. Why is it acceptable just because you're going camping in Africa? It's not. So the first question I would ask myself is this a legitimate use, even though it's off-label, of which there is published experience, there's a body of evidence in the literature, even if it yet hasn't made its way onto the product label, because we know that happens. We know that there may be a time lag. In terms of things like azithromycin in a cholera epidemic, well, then there's a real responsibility to the national community about what you might be doing to drug resistance, to the cholera there. And then I think you have to really look at what the Ministry of Health and the cluster have decided is going to be their approach to antibiotics. And I don't know why they'd chosen azithromycin. Was it for pregnant women or...
I think there is some experience in Bangladesh that the drug regimen was reduced if you used it.
Yeah. I would consider it to be grossly irresponsible to introduce a new class of antibiotic when the health ministry have decided that you've actually got a strain of cholera that for once is still actually sensitive to something as basic as doxycycline. And that would be my response to that. But that's because I would consider it no different from how we choose to use antibiotics in our ICU or anywhere else. You use the simplest molecule from the most simple class that you can.
Well, I don't know what I can add, actually. We are not working on the field, so we have a responsibility because we provide medicine in the name of 50 companies, and we share this responsibility with our NGO partners. So a good way to be sure that nothing bad will be done is to choose good partners and to discuss every day on the phone, on internet, to be sure that every medicine is appropriate, that there is no problem of language, for example. We are now working on some translation of the languages. as we are providing French labelized medicine concerning tulip, we are providing them to French NGOs or NGOs working in French to be sure that at least some people on the field will be able to use our medicine. It's really an exchange with our partner to be sure that none of us is committing a mistake. And the exchange is open. I mean, we are ready to learn that maybe we are doing something wrong and we should change the way we are working. It's really, there's no audit in the way we are trying to punish someone. This is just exchange of experience. The aim is to improve each other and do it better.
Just adding, though, I think what's important is between us, we're actually looking not just at the quality of the supply chain and the use of the drugs, but we're actually also looking, because this is part of my role, at the quality of the healthcare that we're then delivering with these donations. I think that's very important because it's about how they're used, isn't it? And so, you know, we have an exchange of what our results are in terms of wound infections from the project that we did in Haiti, the surgical project, what our mortality rate is for the Haiti cholera response, what our readmission rate is, and so on. And I think that kind of exchange is terribly important to actually evaluate whether what's being done with your donations is actually resulting in lives saved or improved.
Anybody else have any questions? Oh, yes, Janine. Say where you're from, please.
Hi, I'm Jenny Staley from Heart to Heart International. Thank you very much for your presentations, very illuminating. I'd like to ask you how laboratory services comes into play in terms of emergency response. Is there some diagnostics as part of the kit? Is there a need for some diagnostics to support medicine administration and delivery of care, and how might that have the opportunity to improve the care that's delivered and ensure that you're not building resistance to things just because you're prescribing things anecdotally?
So in our kits currently, there are no diagnostic tests. Do we need them? Yes. That's why we are opening up our membership base to medical devices manufacturers of different sorts, because we need to extend what we can offer. This said, it doesn't mean that we don't check the resistances. We check them. We are using local laboratories, whatever facilities, but of course we would need some tests to be efficient. But anyway, as we don't have usable tests, we work on the field with other laboratories to check that.
Oh, you've just touched on a subject which is really close to my heart. So before we get into the micro, so in terms of basic things that we send HemoQs, so you can get an idea of the hemoglobin, glucometers and an oximeter. So at least you can do the basics when you get there. What we really, really want and need desperately in our ideal kit to reply to an emergency is a microbiology lab kit. And that's not so far away as it seems. So Didier Raoult and his group in Marseille, which I don't know, for those of you who don't know, the hospital and research centre at the University of Marseille has just received 75 million euros to become the European Reference Centre for Infectious and Emerging Diseases. It's a really exciting group, and they're one of our partners in the cholera research project. And so what Didier's done is he's come up with a collapsible 8-metre cubed lab, which is pretty cheap. It's about 35,000 euros. They're testing the first prototype at the moment in Senegal. And so it's not ready yet. It's using advanced molecular rapid diagnostic tests, but giving antibiograms as well. And only needs about 2 or 3 days training. So it's not like you have to then find your lab technician who's actually going to be able to do complicated things. In the absence of that, what we've tended to do is collaborate. So, for example, in Haiti, Gesquio and Partners in Health have had a long history there, and I'm sure those of you know it's Paul Farmer and Harvard and so on. So they've got a very good lab, which was subsequently validated by the MSF team, who I know well from France, the MSF lab team. So if there's a validated lab available, then we try and use that. If not, whilst we were waiting to be sure with Gesquio and doing some cross-checks, we have a good relationship with Avicenne here in Paris. And it's actually, I mean, if you think of what's happening in a catastrophe, there's more planes going in and out of the airport than you could throw a stick at. And so we actually just send the samples back to Avicenne and get them analysed here whilst we're waiting to find a local partner. But it's an absolutely essential part of the response, and we haven't quite found the right solution yet. If you've got one, I'd be very interested.
Okay, well, thank you. Oh, you wanted to answer?
No.
I think we need to move on, actually.